Swiss time schedule, so we are just right on time. So I think we will start. So welcome, Marianna Fontana. She's a Professor of Cardiology at the University College London. She works at the Royal Free Hospital in London. We know each other for a long time. We have worked together. We have also did some PhD exams as well. And it's my great pleasure to have her here. She will give us a presentation on cardiac imaging in amyloidosis. She is an absolute world expert on this topic. And yeah, Marianna, so the stage is yours. Please share your perspective on this interesting topic.
Thank you so much, Robert, for the very kind introduction. And it's a pleasure for me to be here today to talk about cardiac imaging in amyloid, which has dramatically really evolved over the last 10 years. So when we think about cardiac imaging in amyloid, I'd like to start from what is wrong with what we have. So first of all, our measurements are extremely imprecise. So here we've got a short axis image from a cardiac MRI scan. And what we did, we asked 10 international imaging experts like head of departments or people who write imaging guidelines to measure the maximum wall thickness. And this is the scatter that we got. So in some of the cases, it's up to 1 centimeter. So we use wall thickness to define disease, and yet it's not a measurement that's really fit for clinical use. The second problem is that when we choose to define cardiac disease based on structure and function, we're not really measuring biology-specific pathways. For example, we define hypertrophic cardiomyopathy as an increase in wall thickness of more or equal than 15 millimeter in the absence of loading condition able to explain it. But by doing so, we are extremely far from the underlying pathophysiological mechanism which is responsible for the disease phenotype and which drives disease progression. The third problem is that in cardiology, we are very bad in terms of linking our imaging to treatment. So if we think about ICD implantations are decisions which are very important for patients and extremely important for society. And yet, we use very precise cutoff of ejection fraction to say if a patient should receive an ICD or not, but we all are happy to live with the fact that if you measure ejection fraction with echo and CMR, you get different values. If you measure with the two different software, you get two different values. And if exactly on the same image, you get two people to measure it, you will get very different values. And in oncology, this is completely different. In oncology, we've got beautiful examples where we've got treatments which targets a specific pathway, and we've got imaging modalities, usually radionuclide agents, which can really follow that specific pathway. So these are, for me, the three big issues that we have when we think about imaging in cardiology. And I would like to, basically, the rest of the presentation will focus on where we are when we think about this problem in relation to imaging in cardiac amyloidosis. So let's start from the first problem, so the diagnosis or accuracy. So when we think about imaging in cardiac amyloidosis, the first imaging test that we all do in a patient presented with heart failure syndrome is an echocardiography. Echo is extremely helpful in these settings. And what we see is that we see a constellation of findings that help us to raise the suspicion of amyloid. So we see concentric hypertrophy, which is very commonly asymmetric, especially in ATTR amyloidosis. We see atrial dilatation. In the past, we used to describe the specular appearance of the myocardium, but now we know that it's really a non-specific finding. This population has been traditionally described as heart failure with preserved ejection fraction, but the ejection fraction is really not a good way to assess systolic function, because while the ejection fraction can be preserved, these patients have got a typical, significantly reduced longitudinal function. In terms of diastole, restrictive impedance pattern is very common, but even just mildly impaired relaxation is not uncommon and shouldn't exclude amyloid. Current pericardial effusion are highly prevalent, but more prevalent in AF rather than TTR. If you want to add specificity to the cardiographic examination, then we should do strain. We strain what we do, we assess the extent and timing of the myocardial deformation during systole. And this is expressed as the peak mean negative strain for each myocardial segment, as shown here. And what we see typically in an amyloid is that there is a reduction on the longitudinal strain in the basal and mid segment with preservation of longitudinal strain only in the apical segment. And this gives the typical bullseye appearance as shown here on the color plot map, where you see that the basal here and the mid segment there have got a preserved velocity, but is only the apical segment which have got a preserved velocity, the longitudinal strain, and this means that you've got this very typical appearance. So what we do with echo is that we can do this formally with, this is an example of one of the scores, or just in our head, we think about all the different findings like LVH, which is concentric, reduction of the longitudinal function, bullseye pattern on the strain. And then we can basically stratify the probability of presence or absence of amyloid in the various patients. But while cardiography is essential to do this, so to raise the suspicion of amyloid and say, oh, this patient, based on these findings, could have amyloid, it's absolutely impossible just based on echo to say, oh, this patient has got cardiac amyloid. So how do we confirm cardiac amyloid? We all have been taught in medical school that the way to do that is to do a biopsy. However, cardiac biopsy are very rarely done, especially in the UK. In Europe, it's slightly different. But anyway, they usually perform quite end stage, in the sense we don't do, as soon as we see an LVH of 13 millimeter, a cardiac biopsy. They involve risks, and it's an expensive procedure. Then one could say, okay, let's go for screening biopsy. And the most commonly performed screening biopsy is an abdominal fat aspirate biopsy. So these, as you can see on the right, is actually quite sensitive in AL. Even in patients with a small amyloid burden, there is 78% of the blood biopsies are positive. But the ATTR amyloidosis, which is now emerging as the most common type of cardiac amyloid, this sensitivity is very low as 15% in patients with wild-type ATTR amyloidosis. So then, let's say, in spite of this challenging, we want to go for a cardiac biopsy. Is the results that we get from cardiac biopsy always the correct one? These are the results of an audit done in the UK across different pathology labs. And what we did, we provide perfectly stained slide, congruent slide to pathologists. And these are the results that we got. The reports were 25%, up to 25% of false positive results. So in 1 in 4 patients, the pathologist will say amyloid is there when there's no amyloid. And in 10%, there was a false negative report. So the pathology will not be able to recognize amyloid when the amyloid was there. And for me, this was very surprising because as a cardiologist, I was really kind of trained to think that actually the result you get from a biopsy is really what the diagnosis is going to be. And why was that? So we learned that congruent staining goes off, so it needs to be refreshed. We learned, to our surprise, that 20% of UK pathology departments do not have polarizing filters. Polarizing filters is an essential requirement to make a diagnosis. And in spite of all these technical issues, expertise is key, because even if you provide perfectly stained slides, there's still 13% of assessors will fail to demonstrate amyloid when the amyloid is there. But the challenges with biopsy don't stop here, because the congruent is just useful to say yes or no amyloid, but then you need to type it. Typing is extremely complex. So the most common method used to typing is histology and immunohistochemistry, but you need really a very wide range of antibodies, and again, expertise is really crucial. And nowadays, mass spectrometry is really becoming the gold standard, but it's rarely available. It's labor intensive, and a lot of expertise needs to be acquired to be able to perform mass spec. So cardiac biopsy is considered the gold standard, but is not acquired early on, is acquired very early, and then the reporting, the diagnostic accuracy of the reporting is not as perfect as we may think. So in the last 10 years, we overcome the challenges of cardiac biopsy and or screening biopsy with imaging. And the transformation really happened because cardiac MRI and bone scintigraphy. So with cardiac MRI in the early 2000s, what we were doing is that we started to give gadolinium-based contrast agent to lots of different people with lots of different diseases. And what we learned is that the pattern of distribution of the contrast within the myocardium is giving us information about the diagnosis in a process known as phenotyping. So a normal patient would have the whole myocardium is black. A patient with dilated cardiomyopathy would have a dilated and dysfunctional ventricle with a mid-wall pattern of GAD. And then you can see here the amyloid where the blood becomes black and there is a line of subendocardial enhancement. And indeed, in 2005, the work from the Brompton in collaboration with the Amyloidosis Centre showed that the pattern of GAD in amyloid was extremely typical. So in normal patients, the blood is gray and the myocardium is black. And in amyloid, there is so much contrast in the myocardium that the contrast goes quickly out of the blood into the myocardium. And then you see this line of subendocardial enhancement coupled with the blood being black, which technically is defined abnormally in kinetics. And because of the incredible value of CMR within the hypertrophy phenotype, then this has been recognized and incorporated in the European guidelines in 2021 that define a characteristic cardiac MRI with diffuse subendocardial transmural late GAD. The transmural is when the whole myocardium becomes white because there is a lot of GAD. And also you will see that a measurement of all the extracellular volume is extremely helpful as well. The second imaging modality that completely transformed our non-invasive diagnostic pathways for TTR amyloid is bone scintigraphy. So with bone scintigraphy, what we do is very simple. We give a bone tracer to look for any evidence of cardiac uptake. A normal bone scintigraphy wouldn't have any cardiac uptake, but then in patients with TTR amyloid, there would be an increase in the cardiac uptake and decrease in the bone uptake. The way we grade this is very, very simple. If you see just a tiny bit of cardiac uptake, then we define it grade 1. If there is moderate cardiac uptake greater than 1, we define it 2. If there is strong cardiac uptake with little or no bone signal, then we define it grade 3. So whilst the differentiation between 1, 2, and 3 is very simple, things can be slightly more challenging. So the first tip is that you have always to do SPECT. So planar imaging is not really enough. And the SPECT needs to be acquired at 3 hours as opposed to 1 hour. And by the combination of the SPECT and planar imaging at 3 hours, we can define grade 0 as absent cardiac uptake on planar, and SPECT CT as well, and normal bone uptake. We define grade 1 with mild cardiac uptake, inferior to bone uptake. The way that to help to define grade 3 is that we can still count the ribs and the vertebrae, but the long bones are difficult to see. And in grade 3, the tip is that you should be unable to count the ribs or the vertebrae easily. But while this seems so simple, actually the spectrum, for example, grade 2 is extremely variable. This one is a grade 2, this one is also grade 2, this one is a grade 2, and this one is a grade 2, maybe 3. But bear in mind, it doesn't really matter if you grade it 2 or 3, because you will see that in the clinical algorithm, they get bundled together. So the only really important is to distinguish grade 0 and 1 from 2 and 3. And SPECT is absolutely important. This is the patients with the rare mutations, female, 43 years old, on planar imaging. I think we all would say this is negative, but actually on SPECT there is evidence of cardiac uptake. So this is actually grade 1. This one, there is a lot of soft tissue and muscle uptake, and you can barely see the heart. So this one, there is actually a lot of cardiac uptake. It's just a soft tissue uptake, and the muscle uptake is obscuring the cardiac signal. So it's a grade 3. But then how do we use bone scintigraphy in clinical practice? So this paper, led by Julian Gilmore, who's the head of center in the institution where I work, within a multi-center collaboration published in Circulation in 2016, really wrote the most important diagnostic paper in amyloid of the last 20 years, probably. And this paper established that if we have a suspicion of TTR amyloidosis, then we should proceed with bone scintigraphy. And if we find grade 2 or 3 bone scintigraphy, as defined as I shown you before, then we need to proceed with blood and urine test. And if serum immunofixation, urine immunofixation, serum free light chains are all absent, then we can confirm a diagnosis of cardiac TTR amyloidosis without the need of any biopsy. And the only extra step that you need to do is TTR genotyping to say if it's hereditary or wild type. And now with this pathway, we diagnose 70 to 80% of patients with ATTR amyloidosis, so we don't need any more biopsy from 70 to 80% of the patients with ATTR amyloidosis. But it's absolutely key to bear in mind that to use this pathway, all these three tests need to be negative. Serum and urine immunofixation and serum free light chains. Because if you have any of these are positive, then you need really to perform a cardiac biopsy to exclude AL amyloidosis, which then will be in the differentials. But then how do we use all this imaging in clinical practice? When we are in clinic as cardiologists, we've got two clinical scenarios. One, less common, which is patient with known systemic amyloidosis, and we want to know if this cardiac involvement. The second one, which is far more common, is patients with a hypertrophic phenotype, and we want to know if this cardiac amyloid. So in patients with known systemic amyloidosis, you have two possibilities. One, that there is systemic ATTR, and one, that is systemic AL. For example, in patients with peripheral neuropathy of ATTR type, and you want to know if there's cardiac involvement, then you can proceed with the bone scintigraphy, because bone scintigraphy is an extremely sensitive technique to detect cardiac ATTR amyloidosis. However, there are some mutations where bone scintigraphy is falsely negative, so you need to be aware of the mutations, and if that's the case, you need to do a cardiac MRI. Instead, in patients with systemic AL amyloidosis, DPD is really not useful to make a diagnosis because it's only positive in 40% of patients. So instead, cardiac MR is extremely sensitive in patients with AL cardiac amyloidosis. But what about the far more common scenario of patients with a hypertrophic phenotype? Here, CMR definitely has got a prominent role because it tells you, yes, it's amyloid, not it's amyloid, but it also informs you about the wide range of differentials that do exist in the hypertrophic phenotype. So I get all the time this question, is CMR better or bone scintigraphy is better? They really sit at different steps of the diagnostic algorithm. If I have a patient with LVH, amyloid could be a differentials, then do a cardiac MRI because it could be amyloid, could be something else. If the only question you want an answer for is the patient has got ATTR amyloidosis, then you can proceed directly with a bone scan. And I'll give you some example of this concept. So this one is a 75-year-old gentleman with shortness of breath, and echo showed a symmetric increase in LV mass, and there is no evidence of plasma cell dyscrasia as assessed by immunofixation in the urine, in the blood, and free light chain. So we have done a DPD scan, and you can see that DPD scan is grade 2, and the echo is consistent with amyloid. And so you can go directly on the right side of the algorithm. The patient has got grade 2 with no plasma cell dyscrasia. We can confirm a diagnosed cardiac TTR amyloidosis without the need of any biopsy. The only extra test you need to do is TTR genotyping. This one is a second case, 77-year-old gentleman with V122I mutation, which is highly present in Afro-Gravian. So V122I mutation in the TTR gene. So he was sent to the amyloid center with suspected TTR. The echo was consistent with amyloid, but this time the patient said the plasma cell dyscrasia. So the patient was sent to us saying, this is likely to be ATTR amyloidosis associated with the viral V122I. So we did a CMR. You can see the CMR is absolutely typical. But then you will see that by using extracellular volume mapping, we can also see if there is involvement with amyloid infiltration in the spleen and the liver. And here there was involvement, which is basically doesn't really happen in TCR. We did a bone scintigraphy and there was nothing on the bone scintigraphy. Now we know that when you combine a grade 0 bone scintigraphy with a characteristic CMR, the probability AL is 99%. But you still need to have a tissue biopsy because you need to exclude rare form of amyloid like ApoA1, ApoA4, or more rarely AA amyloid. This one is the last case, 60-year-old lady with shortness of breath. Again, echo raised the suspicion, and this patient doesn't have plasma cell dyscrasia. So we did a DPD scan, there's absolutely nothing. the patient didn't have a plasma cell dyscrasia. We did a CMR, and you can see there is patchy mid-wall gap, very extensive, but not with a sphenocardial distribution. So in this case, with grade 0 and no plasma cell dyscrasia, the probability of cardiac amyloid is very low. So we reviewed the CMR imaging, and the CMR imaging was consistent with hypertrophic cardiomyopathy. So we briefly talk about how echo, bone scintigraphy, and CMR can be useful to make a diagnosis. But what about tracking changes over time? Because when we see a patient for the first time, the question is really an accuracy question. Has the patient got a cardiac amyloid or not? But when we see a patient for the second or third time, the question is actually a precision question. Is the patient better or worse? And what we need really to bear in mind is that some techniques which are very accurate to assign a specific diagnosis, they're not very good at saying if the patient is better or worse, because the precision is not really there. A LAGAD and DVD scintigraphy are an excellent example of that. These one are two images of leg enhancement taken 3 years apart. And I'm certain that from these images, everybody can say, yes, the patient has got cardiac amyloid. You can see the whole myocardium is black and the blood, and the old myocardium is white and the black is black. The patients had B1 to 2 ATTR amyloidosis, and these images were taken at 3 years interval. So once we can say, yes, the patient's got amyloid, it's absolutely possible based on the image to say the patient is better or worse. So what we need to actually track changes over time is image biology and measure the specific pathways. And we can do that with T1 mapping. So with T1 mapping, what we do now is very simple. With one breath hold, we get one of these images, which is a pixel by pixel quantification of T1. T1 is a number expressed in milliseconds, roughly proportional to the water quantity of tissue. It can be free water or water bound to large molecule like amyloid or collagen. So T1 goes up in amyloid, but the problem with the T1 is that it's a composite signal that comes from the extra intracellular space. And if you want to isolate the signal from the extracellular space, what you need to do is to give contrast, which just goes to the cellular space, repeat the same image after. And by measuring the hematocrit, we can reconstruct one of these ones, which is a pixel by pixel quantification of the extracellular volume. And why the extracellular volume is so important in amyloid? Because the amyloid sits in the space between the cells. So the more amyloid, the more the extracellular volume goes up. And this one is an example of why it's useful to measure the extracellular volume in amyloid. These are patients with ATTR amyloidosis, same increase in LP mass, same degree of systolic and diastolic failure. But if you look at the native one, already you can tell there's a difference. The patient at the top has got a lower native one than the patient at the bottom. And if you look at the LAGAD at the bottom seems to be a bit more white, but it's a bit difficult to tell. But if you look at the extracellular volume map, then the difference is striking. In the extracellular volume at the top, the ECV is 39%. In the extracellular volume at the bottom, there is severe amyloid infiltration with an ECV of more than 62%. And if I go back to the example from before, but now I show you the cellular volume map, you can see the difference is striking. The myocardium went from green to red. And the extracellular volume went from 45% to 67%. So there was a huge amyloid infiltration that happened over the course of 3 years. And because with extracellular volume, we measure the amyloid burden, it doesn't surprise that the higher the ECV, the worse the prognosis in both AL and ATTR patients. I am a cardiologist, so I've been looking at this CMR image for 13 years, but really the only thing I do is that I focus on the myocardium, basically. The head of the Amyloidosis Centre, Philip Hawkins, who's probably the best clinical academic, best I've met in my life, told me, you have to look also the other organs. When you take the image for the heart, I'm pretty sure you image also the liver and the spleen. So then I decided to zoom out and actually to see if it was true that we were imaging other organs as well. And we realized that 95% of the time we were also imaging the liver and the spleen. And we realized that actually we could measure the amyloid also in the liver and the spleen. On the left is the patients with no amyloid. ECV of the liver and the spleen is less than 30. On the right is a patient with severe amyloid infiltration in the spleen and the liver. where the ECV is 78 and 70%. And you can do that just by simply drawing a region of interest into the two organs. So even as cardiologists, we can do that. We validated that against the SAP scintigraphy, which is the gold standard to measure amyloid. And we found that diagnostic accuracy is very high, more than 0.9 to identify moderate to severe infiltration. And you can see that even visually, it's very easy. The patients at the bottom, at the top, there's no cardiac liver and spleen infiltration. Patient at the bottom, there is severe spleen and liver infiltration and like moderate cardiac infiltration. And that's why I really like this technique so much, because basically in one single image, you can say the degree of infiltration in the heart, liver, and spleen. So in the panel A, heart, liver, and spleen are infiltrated. In panel B, only spleen infiltration. The heart and the spleen are blue. Panel C, there's nothing, no heart, no spleen, no liver. And panel D, there is hepatic infiltration and a very mild cardiac infiltration. So, but then the third point, we've seen about accuracy diagnosis. We've seen about tracking changes over time, measuring specific biology, specific processes. And but can we link those changes to therapy? Echocardiography has got some role in tracking changes over time, but this is only in AF rather than TTR. In TTR, there's not really very much. And what we're seeing is that using the change in strain can be helpful to further stratify the cardiac response. There are some caveats there because the change in strain is 2%, and 2% is often within the variability of actually the technique. So once it's useful, there are some technical reasons why probably in clinical practice is not extensively used. But still, a combination of antiproton, troponin, and change in strain can help to basically stratify the disease response. But then what about cardiac MRI? Can cardiac MRI be used in assessing treatment response? This one is a study on 176 patients who underwent with AL amyloidosis, who underwent chemotherapy. We assessed them at baseline 6, 12, and 24 months. And we classify hematological response in the usual way, like percentage reduction in the free light chains, which is basically the new amyloid production. And we classify the CMR response as a difference in ECV of more radical than 5%. And what we found is that at 6 months, there was really no amyloid regression. Amyloid regression was detectable only in 3% of the patients. But importantly, there was evidence already of amyloid progression. So even the patients that were receiving what we would consider a good response, like 100% reduction in the free light chains, if this response was not achieved early enough, they would have progressed by 6 months. So we learned the importance of a quick hematological response. And this one is an example of progression. You can see that the ECV and T1, they both go up. But at 1 year, we were very surprised to see that 22% of the patients actually showed amyloid regression. And all the patients who showed amyloid regression had to have a very good hematological response. So in order to have regression, you need to have massive reduction in the production of free light chains, but this is not enough because not all patients with an hematological response had regression. And this is why CMR is so useful, because if you only measure the amyloid production, you don't really know what's happening to the myocardial substrate. And MRI was really giving us information about what was happening to the myocardial substrate. At 2 years after chemotherapy, we saw an increase in the percentage of patients who regressed, was around 40%. And again, to have amyloid regression, you have to have a complete hematological response. And this one is an example of regression. You can see that at the top is baseline. There was typical features of amyloid. The leg gap was typical, ECV, T1 very high. Second row is after 6 months. Third row is after 12 months. The leg gap is almost gone. ECV was massively reduced. I really like these pictures because when I started to show this picture, it was like almost 7 to 8 years ago, and everybody was saying this is impossible. Cardiac amyloid regression doesn't exist. And the reasons why we thought that it doesn't exist is because it's something that we have been unable to measure, visualize, or quantify. And now that we have a way to quantify it, we can definitely say, yes, amyloid regression exists, and actually cardiac amyloid is a very dynamic phenomenon. And most importantly, what we learned from this study is that the changes in amyloid at 6 months were independently predictive of prognosis. So it was really important to measure what was happening to the myocardial substrate, because that was giving us very important prognostic information. So this is the first time that we were able to build a robust link between imaging and treatment in amyloid. So can we see regression in ATTR amyloidosis? This is a very small study in patients with ATTR amyloidosis with a silencer. And what the silencer does is produces new amyloid production. And what we saw at 1 year, there were no changes in echo. And in CMR, what we saw is that patisiran was typically associated with a fall in NT-proBNP and 6-minute walking test improvement. However, these were patients with peripheral neuropathy as well, so there is a big confounder there. But then when we look at the ECV, we saw that patisiran was typically associated with a reduction in ECV, with an adjusted mean difference between group minus 6.2%. So why this study was important, even if it was very small? Because again, was a proof of concept that amyloid is a very dynamic phenomenon. If you reduce the production, you will get clearance. Could we use DPD to track changes over time? Within this study, we saw that there was a dramatic reduction in the cardiac uptake in the DPD scintigraphy. However, when we looked more closely, we saw that there were changes in the heart, but also in the bone and soft tissues. And so we need to be extremely careful in thinking that the reduction in the cardiac uptake equals less amyloid, because actually there is redistribution with the tracer also in the bone and soft tissues, and the percentage of injected dose that goes to the heart is only 2 or 2.5%. So any big change in the bone and soft tissue will affect the heart, and this doesn't mean it's actually cardiac amyloid deposit. So the DPD is an example of a technique with high diagnostic accuracy, very useful for diagnosis, but not really useful to track changes over time. And this one is my last slide before the conclusion. And this for me was very important because it was the first example of how imaging really transformed the way we think about the disease. This for me started, this publication, these cases that were then published in the New England Journal of Medicine last year, started from kind of a very boring, I would say, Tuesday afternoon. Because in Tuesday afternoon, what I do, I just report scans of patients with ATTR amyloid in the absence of any disease-modifying treatment. So the only thing that can happen is that the patient progresses. And then I came across this scan, which was patients with ATTR amyloidosis V1-2. This was baseline, very difficult features of amyloid. 3 years after, the amyloid is gone. Like wall thickness has gone down, LG has gone down, ECV has improved. So I went to the lead radiographer and told her, you mislabeled the images, just cannot be the same patient. And the lead radiographer, which is much smarter than me, told me, Marianna, is the same patient. Look at the liver cysts, they are in identical position. Anyway, we did some more checking, and this patient was like the same, and everything has gone away. 6 months after, I came across the second patient, same story. Then I thought, okay, it's better to, there must be more. I went to 1,662 patients who had at least 2 echoes in the center, and I found the third one. To cut a long story short, we were able to go back to the mouse model, which we had in the center, and to prove that these 3 patients developed autoantibodies against TTR. And with those antibodies, they were completely able to get rid of the amyloid. But why were these 3 cases so important? Because it was the first proof of concept that amyloid is an entirely reversible condition. If you have drugs which can remove the antibodies, the amyloid, then there will be reverse remodeling and the heart will go back to normal structure and function. And these really all started from a very kind of basic clinical observation with imaging. And it was really CMR that made me understand what was going on, and then we were able really to get to the bottom of these incredibly 3 cases. And so amyloidosis is really a dynamic phenomenon, and we learn this from imaging. The deposits start to build when the rate of formation exceeds the rate of clearance, and when the deposits form, this encourages spark deposition. But the deposits are not static, and if the production is less than the clearance, we will see organ regression. So in conclusion, when we think about imaging in cardiology, we lack accuracy and precision, and we really need to image biology and specific pathways. But what we really need to improve is the link to therapy. The current available evidence of future direction in amyloid is that echocardiography is the first imaging modality very useful to raise suspicion, but CMR with LEGAD and bone sensitivity are really key for cardiac phenotyping and assigning a specific diagnosis. With mapping, we can go a step further and actually image and measure specific pathways, but really the link to treatment is the greatest promise. Thank you very much for your attention.
Mute. Oh, no. So now I could unmute myself. Thank you, Marianna. This was really, really a brilliant presentation showing us all the interesting sides of this amyloid disease, right? That the types of amyloid are different, imaging is important, and at what point, what imaging to use. I would just check our chat. We don't have a question there, but so I will start with the first question. So what I really found striking is that about 1/4 of biopsies were false positive, right? So so this is I always thought this is like a gold standard, and I would think maybe 1 or 2%, but 1/4 is really wow.
For me, that was really a revelation, because as a cardiologist would thought to think, okay, once you get the results of the cardiac biopsy, that is what it is.
Yeah.
And actually, if there is not enough expertise in the center performing the reading, these are the results. And you've seen across the years, there was not a sign of improvement in the sense.
So
it's problematic. Yeah.
And so does this has changed now, or is it better, or do you still see this?
Is really not better, but what's happening more and more is that now the biopsy is sent to a referral center, because I mean, sending a biopsy is very easy. It's not like sending a patient. And so more and more there is a recognition that certain tests should really be performed only in highly specialized centers where you can do everything. You can do from Congo red, typing, to mass spectrometry.
Okay, yeah. So we have to check this maybe for our center as well, how to see the numbers, to draw a better conclusion, because sometimes you might have had some imaging and the imaging was negative, and then the biopsy comes back and is positive, and then you say, oh, what I have done wrong, or you go back to the images, but maybe there is also something with the reference method to think about, because usually you don't question the biopsy, I would say.
I completely agree. We are trained to think that the biopsy is correct, and that's not the case all the time.
So we have now one question from Bangladesh, from Dr. Osmani, and he asks, please comment about discordance between ECG and echo in early suspecting low voltage ECG and LC in echo.
Okay, so basically, low voltage in the ECG is present, but only in a proportion of patients, and is usually more frequent in AL rather than TTR. In a good proportion of patients with TTR, especially V122I mutation, actually we see the typical voltage criteria met. So I agree. Why it's having low voltage on the ECG and wall thickness on the echo is very useful to raise the suspicion. An ECG which meets voltage criteria shouldn't exclude amyloid, because we see that very frequently as well. So yes, it's useful, but not always that.
And question from me: how do you use, for example, pleural effusion or pericardial effusion in your diagnosis? Do you?
Yeah, so when we see pleural and pericardial effusion, we see that more commonly in AL rather than TTR. However, you can see them in TTR as well. So it's just one of those things that are more prevalent in one type, but you shouldn't rely. So, for example, we shouldn't rely on echo or CMR to differentiate between the type. That's very, very important.
And do you report in your reports also the liver and spleen ECV? Do you do this regularly,
Yes,
or
now we started to do that. It took me a few years to kind of feel so brave to report the liver and spleen. But now we report it because usually we do have SCP scintigraphy, which is extremely highly specific, 99% for spleen, liver, and kidneys, and adrenals and bone. We went through a couple of months where we didn't have it for problems with the tracer. And so now we started to provide that, and now we provide it in all patients. And actually it's very useful because if you find an ECV, because in that example of a patient which was sent to us, query B122 TTR, but there was severe spleen and liver infiltration, we knew even from that the patient was going to be AR. So it's just something that we image all the time. There's no reasons why we shouldn't report it.
Mm-hmm. Yeah. I think we might start to do this as well. We will run. Do you have what's the normal value for ECV in the spleen and the liver? Is it different?
Normal value is 30.
Mm-hmm.
And then gray zone is between 30 and 40. Between 30 and 40 is really you can't draw any conclusion. Often congestion is there. But if you see more than 40, it's likely to be infiltration.
For liver and spleen?
Yeah.
For both. Okay. Good to know. Thank you.
I have also a question, perhaps. Thanks for this fantastic presentation, this wonderful overview of this still quite complex disease. As far as I remember, you didn't mention CT, and we are improving our CT skills also in regards to myocardial assessments with recent technology, photon counting detector CT. We now start looking at also the extracellular volume. We got more robust with these new techniques. Do you have experience with CT assessments of extracellular volume in these patients?
You're completely right. ECV is emerging as an important tool, especially in patients who undergo TAVI. So in all patients who undergo TAVI for severe AS, we do a CT. So acquiring that extracellular volume can be extremely useful because it gives a probability of presence of abscess of amyloid, so we can select from there the patients who then should go and have a DPD scan. Mm-hmm. And so that's, I agree, is a very, very kind of useful technique and for now, probably that's the predominant clinical applications, I would say. But maybe in the future will be also used for other things like tracking changes over time. I mean, acquiring the SCV CT takes 5 minutes as opposed to 45, which is an MRI. So it's entirely possible that whilst now the role is really mostly in clinical practice restricted in severe AS undergoing TAVI because they have to anyway, in the future it will really be expanded. But even just that clinical application is very useful because we know that the prevalence of amyloid can be between 10 and 15% in patients with severe AS. So having the CT as a screening tool to decide which patient should have a bone scan is actually very useful.
Okay, thank you.
So we continue from this chat. There's one question. Several chronic inflammatory processes can predispose to amyloidosis, such as sarcoidosis. How would cardiovascular imaging help in differentiation of etiology, raise red flag to improve the diagnostic accuracy?
Yeah, so this one is the AA amyloidosis, so the one related with inflammation. So anything that causes a chronic inflammatory condition which is sustained over time could lead to AA amyloidosis. So we've seen a massive reduction in the prevalence of AA amyloidosis because now with all the new biologics and antibodies, we have seen there is a much better control of inflammation. So it's extremely rare to see cardiac AA amyloidosis. So in our experience, cardiac MRI is very sensitive to see cardiac AA amyloidosis. It really doesn't give any positivity on bone scintigraphy. And it's very important to bear in mind that when you have significant cardiac amyloidosis of AA type, the prognosis is extremely, extremely bad. You're talking really a few months.
Mm-hmm.
But yes, so from an imaging point of view, you do a cardiac MRI. However, don't use cardiac MRI to distinguish between the type because they will all look identical. But of course, if you put together patients with a chronic inflammatory condition with persistently severe elevated level of CRP over time, you start to see cardiac amyloid and you exclude the plasma cell dyscrasia and you do a DPD and you include TTR, then you know it could be AA.
Yeah, that's interesting because this is not so prominent in the community right now to speak about this AA amyloidosis. It's this or that, and if both are negative, the CMR was false positive. So we have to really have in mind this chronic inflammation is an important topic. Hatem, do you have another question, or shall I continue with the chat?
No, please continue.
Can we comment positively for amyloid if there's no LGE, or hard to find out when there is increased T1 mapping and high ECV? Have you seen cases like this?
Yeah, absolutely. You can see plenty of cases of both TTR and AL where there's no leg gap but raised ECV. So, for example, in systemic AL amyloidosis in patients with renal involvement, you almost always find increased ECV in the range of 35, 38 with no leg gap, and that you know is early cardiac amyloid infiltration. I mean, one of the problems is that a mildly raised ECV is a non-specific finding. So if you don't have any suspicion of amyloid, seeing an increase in ECV, you can't really say what it is. But if you know that there is systemic amyloidosis and you've got an ECV of 35, that is definite early cardiac amyloid infiltration.
Yeah, that's very helpful because we sometimes have this situation as well, and then yeah, it's difficult to report and that we suspect amyloidosis. Then you get these answers back. Yeah, do you see in every patient now amyloidosis? Because we tend to be, yeah, then too oversensitive. So I think you've faced these discussions as well at some point. Yeah. Thank you again, and we are already planning the next round for 25. So this series will be continued.
Thank you so much. Bye.
Thank you.